Working on examining age and sex-related differential item functioning in patient-reported outcome measures. In recent years, there has been tremendous interest among healthcare decision makers, researchers, and even clinicians to integrate patient-reported outcome measures into health service evaluation, as well as comparative effective research. Before I proceed, I would like to define what patient-reported outcome is. So patient-reported outcome or patient evaluation of their own health status. Patient that has series of questions in order to gauge their own health and health-related quality of life. To be specific, patient-reported outcome are used in the management of cardiovascular diseases to evaluate the effectiveness of treatment intervention, compare the health status of population group, as well as to evaluate the quality of care provided to patients. But patient-reported outcome measures are subjective. Unlike death, that you can measure is someone either alive or dead. This is based on individual response. You cannot measure like, okay, straight away, it's just dead, alive. It's not objective, it's subjective. So with the subjective nature of PRO, accurate interpretation of PRO scores are essential for valid interpretation, for valid policy decision making, as well as clinical decision making. So actually when we use PRO, we want to measure actual true change over time. But this true change can be confounded by differential item functioning. And that brings me to what is differential item functioning. So what is DIF? DIF occurs when group of individuals with the same underlying level of health respond differently to the same problem. And when this happens, we'll be comparing two things that are not comparable. When we go ahead to compare such, we're entering into the issue of measurement bias. So with different responses, we'll be entering into the issue of measurement bias. I'll give you an example of DIF. With age, people tend to interpret questions differently the older they become. Female tend to interpret questions differently than male. You might not believe this, but women are more likely than men to endorse an item on having crying spells, even though they have the same level of depression as the men. With this different level of item endorsing, this is increasing a kind of negative score for the women, when in actual fact, their underlying level of health has not changed. So with this, that brings us to the objective of the study. We want to investigate the presence of differential item functioning with respect to patients' demographic characteristics in the Seattle Angina Questionnaire administered to individuals with acute coronary syndrome. I'll explain a little bit about the Seattle Angina Questionnaire. It's commonly used validated cardiac disease-specific prompts, and it has 19 items. So see the items like individual questions, like let's say there are 19 questions that are asked. And I would want you to picture this like question 1 to question 9 is being aggregated into one, and that is what is known as the physical limitation domain. So these 19 items are being grouped into subgroup, and that is what is known as domain. So we have 5 domains: physical limitation, angina stability, angina frequency, treatment satisfaction, and quality of life. And I would like to say here so that it's not sufficient to have the domain level to be unbiased. We need individual item level to also be unbiased. So if females are responding differently than male on an item, we also want that to happen at the domain level and vice versa. For us to say, oh, yeah, this item is not, or this domain is not being biased. So the data for the study is from our Alberta Provincial Project on Outcome Assessment in Coronary Heart Disease, and we'll be looking at 2008 to 2014 specifically. So this is a little bit of descriptive about the data. So like, total sample size is 3,864. There are more data, but we used only complete data for each of the items, on all items. So 83% of our sample is less than 75 years old, and 78% are male. So we have more male, and we have more people that are younger than 75 years. So for the analysis, we did ordinal logistic regression at the item level to check if there is differential item functioning. And then we use multi-group confirmatory factor analysis at the domain level to check if there are different item functioning here. So for the multi-group confirmatory factor analysis, we test 4 different forms of measurement equivalence. Now, see differential item functioning. If they do not have differential item functioning, then there will be measurement equivalence. If they do have differential item functioning, then there won't be measurement equivalence. It will be invariant. So, and then we check that on configural invariance, in which all parameters are relaxed, metric invariance, intercept parameters are constrained, and then the strong invariance, intercept and factor loadings are constrained. Then the strict invariance, we have intercept, factor loadings, and variances are constrained. Then for the complete invariance, all parameters are constrained. So for the confirmatory factor analysis, the way we check the model fit is that we check if the root mean square of approximation is less than 0.08, or the comparative fit index is greater than or equal to 0.95. So a measurement invariance is considered if any of these 2 conditions were satisfied. If the log likelihood ratio test is based on the difference in the model chi-square, and the change in RMSE less than 0.015, and the change in CFI less than minus 0.01. For this study, we did not use chi-square difference because this is based, it's based on the sample size, and it's not stable. So if the sample size increases, you kind of have a weird result. So mainly we base the result on change in CFI. And also for the ordinal logistic regression, the approach involves sequentially regressing each ordinal item score as a function of their domain score, as a function of their grouping variable, which is the sex and the age group. An age group is categorized as less than 75 and greater than or equal to 75. And also as a function of their domain score, grouping variable, and the interaction between domain score and grouping variable. We check for uniform DIF and non-uniform DIF, but I'll just leave it as we test for differential item functioning, because that is another level. And then if the change in house squared is greater than 0.035, then we'll determine that there is differential item functioning on that. Otherwise, there is no differential item functioning. And this is the results we have. So before I go through this results, I would like to, like I was explaining, configural, metric, strong, and partial strong. I didn't talk about partial strong previously, so I would like to explain a little bit about that. So if you go through the configural invariance and then you did the metric invariance, you compare the results with the configural invariance. And that is why we did this subtraction, changing CFI. But in a situation whereby you could not meet strong invariance, then you relax the parameters, and then you check partial strong invariance. And so that is what happened above here. If you look at this side, when I was mentioning the condition, if it's less than minus 0.01, so here, the difference between these and these gives negative 0.017, which is actually less than minus 0.01. So because we could not meet strong invariance, we relax the parameters to meet partial strong invariance, and then we have 0.011. So among overall for the age group, we were able to meet partial strong invariance. We're able to satisfy strong and strict invariance for the overall sex group. I did not report that here, but we also did the comparison among those who are less than. So we compared age group. We compared age group for less than or equal to, we compared female, less than or equal to 75, less than 75, and then male as well. So in conclusion, For this data, the comparison of the SAQ item at the domain level across age and sex group are unbiased. So there is no differential item functioning here. So there is measurement equivalence. It's not measuring difference, so it's not biased. So I think it's a good thing that cardiovascular researchers can be confident that the SAQ scores are unbiased, and the comparison, you can compare them across age and sex group. We did not look at education or any other subgroup in which they might be biased. But for this study, yeah, that's what we got. Thank you.
Five minutes for questions. Any questions here? Please come to the mic.
Thanks, that was a great talk. I'm really interested in differential item functioning too, and for latent variable models. So age and sex are common variables that we have and that are of interest in looking at something like differential item functioning. If you had the sky was the limit in terms of variables that you could look for differential item functioning on, what would you be most interested, or what do you think's, and also what do you think's most relevant for clinicians to understand in terms of where there may be differential response patterns, is one question that I have. And then a second one is just around considering also mixture models. So where you have I talked this morning about latent class models as well, so recognizing that there can be heterogeneity and that we might not have measured variables associated with it, but that there might be patterns of variation. So have you thought about using latent class analysis? Yeah. So those are the two questions I have.
So to your first question, I think ethnic background would be one of the things they should consider. That's my thought. I've not tried that, of which I have the data now, so I can, play around with it and do more stuff. But from my observation, like somebody from Nigeria, we kind of have malaria in which they don't have here. The way we respond to treatment is also different. So that's something that I think they can also try. Different backgrounds can also influence, differential item functioning as well. Then to your second question.
Latent class analysis. Groups that we may not even know about, using a latent or unobserved variable approach to look for heterogeneity.
Yeah, so that is a big picture where I'm going here. So it's what I'm actually going into, but I just started from this. So we're using the unobserved, which is the latent class, to check if there is any unobserved influence on it. So, and I'm using M+. So right now I don't have a summary result to show you, but I'm very sure in the next few months I should have something to share with you. Thank you.
Thank you very much, Zoe. Our next speaker is Jacqueline Harris. Jacqueline comes to us from the Computer Science Department at the University of Alberta under the supervision of Dr. Russell Greiner. She is a member of the University of Alberta Computational Psychiatry Research Team and on the AI student ambassador with Intel. Jacqueline's research is a continuation of her work as a research assistant for Dr. Glenda McQueen at the University of Calgary in collaboration with the Canadian Biomarker Integration Network in Depression, or CanBind. She has a Bachelor of Science degree in Life Sciences from Queen's University with a minor in Computer and Information Science and a Master of Science from the University of Western Ontario in Medical Biophysics. Her research is primarily focused on predictive modeling in depression and feature extraction techniques for functional magnetic resonance imaging, MRIs. Please welcome Jacqueline Harris.
There you go. Can everybody hear me okay? Okay, Thanks. Yeah, thank you so much for having me today. It's a real treat to be here, celebrating sort of women in data science and the work that we're doing. So as I was introduced, I am a PhD student at the University of Alberta, and the research that we do in our lab focuses on applications of machine learning to medicine. So this is a really great conference to be talking about that. And today, sort of, I want to walk you through first just why we care about psychiatry and how we're incorporating machine learning and artificial intelligence into that domain. I'll go on to discuss machine learning a little bit, which I think a lot of people consider a bit of a black box still, and then talk about some of the research that we're doing involving functional magnetic resonance imaging. Before I went to go to the University of Alberta, I was working here at the University of Calgary as a research assistant. And it was a really fantastic opportunity, especially for somebody in data science, to have a bit of a unique opportunity to work with the patients from whom we're collecting our data and see sort of hands-on how we're collecting the data and the experience that these individuals are going through when they have a psychiatric disorder. So for those of you that aren't necessarily familiar with the path these individuals would have when it comes to getting treatment. If you suspect that you have a psychiatric disorder, usually what you do is you would go see your family doctor, clinician, go to a walk-in clinic, and you would say, I'm not really feeling like myself. And during this conversation, you would sort of have a bit of a structured interview. Your doctor or whomever would ask you a number of questions about your mood over the last few months, how you've been feeling, your attention, sleep problems, things like that. At the end of that, they would make a determination based on those symptoms as to whether or not you have some sort of psychiatric condition, and then on top of it, which one they think it is. Now, I think we can sort of see there's a bit of a problem with that. The way that we diagnose psychiatric disorders hasn't really changed in decades in the way that we've been treating them. So it's completely subjective. It's based off of what you're able to tell your clinician about how you're feeling and what they're able to sort of draw from that. So moving forward, we'd really love to have sort of objective ways to do this. If you think about a number of other sort of disciplines in medicine, we often have blood tests or neuroimaging scans that we're able to do to make a more sort of objective diagnosis for these individuals. On top of that, when it comes to treating these individuals, there's no real guidelines necessarily to which treatment is going to be effective for which individuals. So coming up with ways to have a test to tell them, should I be diagnosing this person with this condition, and should I be treating them with this medication, or perhaps prescribing something like CBT or some sort of neurostimulation. So that's really an opportunity, I think, where machine learning and artificial intelligence can come in to improve the way that we're treating our patients. There's this really interesting quote, and it comes from a story that Dr. Tom Insel has told about a time that he was giving a talk. So Tom Insel is the former director of the NIMH in the United States, so the National Institute for Mental Health Research. And he says he's giving this talk, and he was researching, I believe at the time, oxytocin. And he gives this big talk about, all these sort of, what are the causes of mental health disorders? What's the difference between people with psychiatric disorders and healthy controls? And someone from the audience stands up and says, "Excuse me, but our house is on fire, and you're talking about the chemistry of the paint." And I think this quote is really great and sort of underlies, Sorry, I went too far. Underlies the problem in the way that we're treating our patients. We spend a lot of time thinking about what is the cause of mental health disorders, but we need to sort of change the way we're treating our patients and do something for them to improve what's happening now in the way that we're treating them. And that's where sort of machine learning can come into play. So this is sort of for the talks I give, I usually sort of like to walk through just the general way that we use machine learning and what the setup looks like for us. So usually when we're building models, what happens is we just have a spreadsheet of data to work with. That's usually often a starting point for us. So in this spreadsheet, the rows here would often be some sort of sample. And when we talk about that in medicine, usually these are patients. So data from a given patient that we want to look at. The columns then would be different kinds of data or different pieces of information that we have for those patients. So again, in medicine, often things we look at and consider are things like demographic information. So the patient's age, their gender, things like that. You can also include results from blood tests, different levels of different proteins and things like that, or different genomic information. Then, in the case of supervised machine learning, which I'll be talking about today, you would have some kind of label for those individuals. So oftentimes, we're looking for things like a diagnosis. Does this person have a disease or not? You could be interested in, are they going to respond to a different treatment? Something like that. So the labels for us are going to be these pieces of information that we're really interested in. There we go. So these would be maybe diagnostic labels. So does somebody have a disease or not? The point then, and what we're really trying to do, is build a model that can map us from the patients and the features. So the information that we have collected from that patient, can we build a model that will then map us to these labels that we're interested in having? The hope then is that if a new novel patient walks into the clinic, we could collect those same pieces of information, give them a blood test, collect demographic information from them. And using that model that we already trained on the patients that we already knew whether or not they had a disease, we could make a prediction about whether or not that person has that condition or would respond to that treatment. So the point of these machine learning models is really to make predictions about people we haven't seen yet based on those that we have. So the work that I do is specifically interested in how we're using neuroimaging in these applications, and I think the connection between psychiatric disorders and neuroimaging the brain is pretty obvious. It's the center of sort of our behavior and our emotions. In particular, when I'm talking about neuroimaging, I'm talking about magnetic resonance imaging, or MRI. We really like to use MRI for neuroimaging, first off because it doesn't have any ionizing radiation, so it's a relatively safe imaging modality to use. The other thing is it's fantastic for looking at soft tissue. And there are a number of different qualities of the brain that we can sort of probe at using MRIs that are particularly interesting when it comes to psychiatric disorders. So for those of you that don't know, there's usually sort of 3 broad categories of images that we look at. Structural images, over here, are just sort of your run-of-the-mill anatomical images. So if we want to look at the shape of the brain, the size of different structures, how big are the ventricles? What does the surface of the brain look like? There are a number of interesting sort of qualities that we can probe from that. What I'll talk about today specifically, and what I'm really interested in, is actually these functional magnetic resonance images, or fMRI. So this is actually a 4-dimensional image type. So it's looking at the activity of your brain over time. So we collect an image of your brain, a 3D image, approximately every 2 seconds. Give or take, depending on the scanner. And we're able to then look at contrast changes in different regions over time, making then connections about what kind of circuits exist in the brain. How are different regions talking to each other, and how active are they at rest or during different tasks? The last sort of type of image that people often use is diffusion tensor imaging, or DTI. And this is sort of, again, another type of structural image. You're able to sort of look at actually physical connections that exist in the brain. So looking at white matter tracks. How is one region of the brain physically connected to another, or are there compromises that exist because of certain disorders? The question then is, if we're going to use neuroimaging in a machine learning application, how do we go from these images that we have to that setup that I showed you before? How do we get these into the table? So a naive approach that actually isn't necessarily that naive, it's something people use all the time when it comes to computer vision, is you could simply vectorize this image. Every image is just composed of a set of pixels or voxels. These each have a grayscale value associated with them. You could simply stretch out these pixels into a long vector and use them as the different features to input into your images or into your model. And this is a little bit problematic when it comes to imaging. So there's a couple things we usually consider when we're building machine learning models. The first being, are these features really meaningful to us, right? If you just take a bunch of grayscale values, is it really that important to us that one of these voxels has a grayscale value of 46? What does that mean for all the different patients? You can probably do a little bit better when it comes to the features that you're using. So how do we transform that into something that's meaningful to us? The other issue is that when it comes to MRI, these images, they often contain millions of voxels. So when it comes to big data, unfortunately, when we're talking about it, what we'd like to see is a big N. So we want lots of rows in our tables. We want to see lots of samples for the models to learn off of and build. And that's where sort of the success of these models has been built off of, is more data. Unfortunately for us, in medicine, if you've worked with machine learning in medicine, oftentimes our models are big, sort of in the number of features, and we often struggle to get large sample sizes, especially when it comes to neuroimaging data. This is an issue because of the costs associated with these studies that we run, the difficulty in recruiting patients, and privacy issues and things like that when it comes to sharing data. So if we're planning to use these neuroimages in our models, we really have to think about how we're going to reduce the dimensionality. So we really need good quality features with lower dimensionality. And we see this effect of sample size, the problem with not having big enough samples, if we look at the literature and the samples that have come out and the models that have come out when we're talking about psychiatry in the past. So this is from a review paper, Wolfers et al. In 2015. And they were actually interested in classification studies that had come out in the past in psychiatry. So looking at diagnosing schizophrenia, bipolar disease, depression, and other sort of disorders that you can see labeled by the different markers here versus healthy controls. So you can see here at the bottom, we have the number of patients going along the bottom here and the accuracy of different models going up here. So if you kind of look at this, there are actually models that people have published in the literature with extremely high accuracy, so pushing 90% up to almost 100%. So to some extent, you could say it's done. I mean, we've solved it, right? We have models up here pushing 90, 100%. But the issue is, as soon as we grow the sample size, we see sort of this paradoxical effect where the accuracy actually drops off, which is the opposite of what you'd expect sort of from machine learning. Generally, the idea is we get bigger sample sizes, the models are able to learn more about our population, we should be seeing an improvement in accuracy. But this is actually the opposite of what we're seeing, and that's actually a huge problem in the way we're building these models in psychiatry. We don't have enough people to be building these models, and it often costs us in the long run. The models don't generalize well. And that's a major issue for us moving forward. So there's been a big push in psychiatry to get these bigger sample sizes, to work with more people, so we can build robust models that will actually generalize well to the general population. So at this point in time, I just want to talk about, now that I've sort of introduced why we care about machine learning in psychiatry and AI, and how we're using it, talk about some of the work that my lab has been putting out looking at diagnosing schizophrenia using these brain images. So this paper actually came out earlier this year. It was a really important paper. It came out in Nature Schizophrenia by one of the postdocs in our lab, Dr. Sunil Kalmati. And what they wanted to look at is, can we diagnose schizophrenia? So they had 174 patients from NIMH Nimhans in India with approximately 81 treatment-naive patients and 93 healthy controls. And they wanted to do this fully based off of just the neuroimages. So this would provide us with sort of an objective means for diagnosing individuals. Could we just give them a brain scan and then predict whether or not they have schizophrenia? And the features that we tried to use are completely taken from the neuroimaging literature. So this is where it becomes really important if you're working in data science to know the type of data that you're working with, how to work with it effectively, and what features would be really interesting to you. So they tried to work with two types of features here. The first is regional features, so looking at a voxel level, calculating different measures. So they used ALFF, FALFF, and REHO. And just for example, REHO is a measure of how similar the activity in a given voxel is compared to the neighboring voxels. They also looked at a number of different functional connectivity measures. So these are the measures not just calculated at voxel level, they're calculated between sort of voxels or regions. So is there a correlation or a relationship between the activity of one voxel or one region with another region. So they were able to calculate those as well. Then if sort of following what I had mentioned before, it's really important now to think about how we're going to reduce the dimensionality. A lot of these are calculated on the voxel level, or if you're talking about functional connectivity, you're actually calculated between a number of different regions. So what they also wanted to look at were brain parcellations. So again, in the neuroimaging literature, we have a number of these a priori brain parcellations. So there is sort of an active field of research looking at how can we parcellate the brain and how we can push together similar regions. So the parcellations themselves can be based off of a number of different things. We can look at sort of anatomical parcellations, so grouping together regions of the brain that have a similar anatomy sort of defined in the literature. We can also look at more data-driven approaches. So are there regions that have similar activity, that they often fire similarly together? So why don't we just push the activity of those regions together? So we have a number of atlases that are creating regions of interest based on different characteristics of the brain. So when it comes to putting these into a machine learning model, we have these different feature types that we've calculated from the images, so those regional and the functional connectivity. And we also have a number of different types of way of reducing the dimensionality. So we can use any of these atlases to average the signal over a number of different voxels and look at it that way. So one of the questions we can come up with and things that are of interest in our research is, okay, well, is there a combination of those two things that would work the best? Is there an atlas and a feature that would provide you a higher prediction accuracy? And what Sunil sort of thought of also was each one of these different feature types and different atlases is sort of built off a different type of information. So using one type of atlas and one type of feature may not provide you the whole picture. Is there an added value to using these all together in sort of an ensemble, using an anatomical atlas along with a functional connectivity atlas that would provide you additional information that's important for the classification problem? So he tested a number of different streams of research or different models. So it looks like a lot, so I'll just walk everybody through as best I can. So the idea is, starting with a single subject, what we would do is create each type of combination that we could. So each feature type and each atlas. So we have these sort of single source classifiers. So up here you can see, looking at ALFF, matching it with each one of the different types of parcellation atlases, train then a logistic regression to see if you can classify whether or not an individual has schizophrenia. So that's one thing to look at. We also wanted to look at the stacked accuracy. So looking at one feature type again, say ALFF, using all of those different type of atlases as inputs to train a logistic regression and see if that performs better. Then finally, taking all of this information together, and again, trying to build a new classifier based off of all of that information. And for this final classifier, if you're a bit keen, you might see that this would actually provide you with a lot of features. If you use all the different types of features that I talked about, along with all the different types of atlases, you'd actually get a large number of features to be working with. So we used principal component analysis prior to this training to reduce the dimensionality. So these are the results. So I'll walk you through them again. So along the bottom here, you can see all the different types of atlases that we used. And there were 14 atlases in total with various, based on various different features for combining the voxels. Along the y-axis here, you can see the average accuracy at test time. The different colors of the bars represent the different feature types, so you can see how well the different features performed given the different atlases. And you can see there is actually quite a bit of variability amongst the atlases and the features. So these types of decisions, when you're building your models, actually can have a significant effect in the performance of your model. So I highly recommend, if you're in the business of building models, testing these kinds of things out. It's important to sort of figure out what's going to work best for you. You can also see, though, here in this last sort of section, these are the stacked classifiers. So using all these atlases together with the different feature types, you can see that they often perform better than any one of the atlases by themselves. But what's really interesting and sort of the take-home of this paper was that actually using all of the atlases and all of the feature types in this sort of giant stacked classifier outperformed any of the other single source or single feature classifiers, which is really interesting. So it seems like there was some additional information that could be gathered, not only by using all of the atlases, all the different sort of parcellations, but also from each one of these different feature types. And this represents sort of a really great paper in the literature, again, because we were able to build a classifier that was strictly based off of sort of objective markers. We gave somebody a brain scan, and then you're able to sort of predict schizophrenia. He did, in the study, some things to note. It is strictly based off of treatment-naive patients. So these are individuals' first episode schizophrenia, so that removes some of the confounding effects of treatment on these individuals. So when I arrived at the University of Alberta, this work was sort of just coming out, and it was really interesting for me. I had been working with Dr. Glenda McQueen here at the University of Calgary on this large national study called CANBINE, which is the Canadian Biomarker Integration Network in Depression. And we actually had kind of a similar data set when it came to looking at this. We had actually more participants. We had approximately 254 individuals collected from 6 sites across Canada, 153 of which had depression, and we had approximately 101 healthy controls. So for me, the interesting thing at this point was we have this really great classifier that seems to work well in schizophrenia. Is this something we can reproduce in depression? And these are very new results, and unfortunately for us, or for me, we're not seeing the same effect in depression. It seems like none of the classifiers are really able to pick up very much. You can see here the stacked classifier isn't really doing much better. And this black dashed line here, I didn't quite explain it in the last slide, but it is actually sort of our default accuracy. We had about a 60-40 split between the individuals in the study between healthy controls and those with depression. So at this point, in this data set, we really weren't able to find a really good classifier for depression. But it underlines some important points, some differences between the two studies. So like I mentioned at the end of when I was talking about the last graph, the data set they had used for the previous study was looking specifically at treatment-naive individuals. So we have this remaining question in psychiatry. We don't understand what is the effect of having a psychiatric disorder over time. Are there changes that occur in your brain? If you're somebody that's experiencing your 10th episode of depression, are you going to look a lot different than somebody who's on their first? We also don't know the effect of treatment. And CANBIND, we didn't actually screen individuals for what episode they were on or what sort of treatment they had had previously. So we have a lot of a mix of different types of people, which may be causing some difficulty in the way that we're classifying. The other thing to note, which I think had been brought up earlier, is that our data was actually collected from 6 sites across Canada. So when it comes to neuroimaging, and I think in a lot of the omics studies, you have to consider the fact that data collected from different sites will have an increased amount of variability. And this causes a lot of difficulties for us when we're trying to run these huge multi-site studies. We do have an increase in the number of participants, but unfortunately, when we combine that data, oftentimes we see no increase in the performance of our models because of that variability, and sometimes even a decrease. So the area of batch effects, how we're dealing with combining data, is actually sort of an ongoing field of research for us. When it comes to depression, though, one of the things we're sort of getting into in the work that we're doing and in the field is really what is depression and the way that we're sort of thinking about it. So when it comes to diagnosing MDD, or major depressive disorder, the DSM-5, which sort of outlines how we are actually diagnosing these individuals, they give us about 9 different categories. So things like depressed mood, diminished interest, changes in appetite, sleep, psychomotor agitation, retardation, loss of energy, feelings of guilt or worthlessness, diminished ability to concentrate, and recurrent thoughts of death or suicidal ideation. So if you kind of look at this list, you might notice there are a lot of things that seem almost the opposite of each other. Things like weight, appetite increase or decrease, insomnia or hypersomnia. So what we end up with, to have a diagnosis of depression, you have to have at least 5 of these, 2 or 1 of which must be these first 2. So you end up with a lot of people that are diagnosed as the same thing, but look incredibly different. You can have many different ways to meet the criteria for depression, but with very different characteristics. And to some degree, in the field of machine learning and psychiatry, we're starting to really wonder, should these people all be grouped under the same diagnostic label? And it makes it incredibly difficult for us when we're talking about machine learning models to try and separate healthy controls from everybody that would meet this criteria. So in the models that I presented previously, I was talking about using logistic regression. Logistic regression is a linear model. So essentially we're trying to find a plane in a multidimensional space that would separate 2 people. And this plane has to be straight. It's essentially a straight line. So if there's all these different types of groups, what are the odds that there actually exists a straight line that would separate every healthy control from everybody that would meet this criteria? So we're starting to think about, okay, what are our other options? Are there better ways to find more homogeneous groups of people that we can start looking at and separating and determining, are those a separate disorder? Are those individuals that we can treat differently and deal with? And one example for us with depression and sort of the aim actually of Cambind is looking instead at healthy controls versus people with depression is the question of what treatment should we be giving these people and treatment response. So the interesting thing when it comes to depression actually is, even though it's so prevalent and so many people are suffering with it, there are actually a lot of different effective treatments for depression. A number of different types of medications people can use, different types of therapy they can receive, so things like CBT and talk therapy, or different types of neurostimulation. But the problem that we run into in this domain is that we don't know which treatment is going to be effective for which person, and there's quite a bit of variability into what treatment people actually respond to. So instead of using perhaps diagnostic labels, labeling somebody with depression, we could focus on, did this person respond to a treatment? Given they met the criteria for depression, if we gave them a drug, would they respond to that treatment? And hopefully that's a bit of a more objective marker to be looking at. Would those people look a lot more similar based on their neuroimaging scans? So that's sort of where we're going in the future. Can we look at instead treatment response, which perhaps might actually be a more pertinent and more interesting clinical question for us? So thank you so much for listening. It really is a pleasure to be here. I just want to say thank you, first of all, to the University of Alberta, Dr. Sunil Kamadi and Dr. Russ Greiner, the whole Cambind team. There's a lot of work and effort that needs to go into collecting something like 300 participants across Canada and a lot of funding. So thank you to everybody and all the institutions that are involved in this work.
Thank you, Jacqueline. We have some time for questions, almost 10 minutes. So if you'd like to ask a question, please come to the mic. Here, I'll put you on here. Nope.
Oh, I've got lots of questions. Thank you. That was such an interesting talk, and I think some of the challenges that you have identified in terms of heterogeneity in your populations, whether there are site or batch effects, and also the fact that you have what would be called noisy labels, right?
Yeah.
That there's error in your labels are quite some common problems. And I guess a comment, first of all, in terms of how you deal with them, and I'll get your feedback, but I guess for me, it's often about trying things different ways,
Yeah.
right? The sensitivity analyses and saying, well, when I try something a different way and make different assumptions, because you're making, you've talked about the analyses and there's many steps involved and you're making assumptions all along the way,
Yeah.
right? So the importance of acknowledging those assumptions and then trying things a different way with, say, a different set of assumptions, so your sensitivity analyses, I think would be very important. So do you want to start by talking about how you do that? Or do you do that? Or are you thinking about that?
I'm thinking about that. We're sort of, it was, for me, I'm just in the second year of my PhD, so we got here and I really just wanted to try this out for size. And unfortunately, it's not really working the way I'd hoped, but that's part of the research. So I think
that's probably wasn't all that surprising.
Yeah.
Though, in some ways,
I get
right?
like really anxious and excited every time the model runs, hoping something will pop out. But yeah, it wasn't necessarily a huge surprise for us that this didn't work on the first run. So I think we're actively sort of seeking techniques and ways to sort of explore the space a little bit better. And I think when it comes to the labels, it's a really challenging space. We see a lot of people sort of try to look at things like clustering and sort of unsupervised learning methods. But I think at the same time, we've seen some papers come out, and I'm not necessarily how sure those stable those clusters and things like that are going to be when you move to a different data set. So it's coming up with clusters and things that are stable in your data set that you can use when you move to another site or another study, and are biologically meaningful. So I think, we're sort of, it's an active field.
Yes, absolutely. I don't think there are any silver bullets there, right?
Yeah, and it's all about playing around and seeing sort of what works and
playing around, but I think in a very structured way is important. That one of the things I've seen with some of the computer science students we work with, even in our Veda program, is that they can be very quick to say, well, we can try this, this, and this, without necessarily documenting and saying, how does that line up with the assumptions that we have about the data?
Right.
And one of my points of emphasis has been anything that you do needs to be reproducible.
Absolutely.
Right, and it needs to be very transparent in terms of those processes, so that others can try the same thing and see if it in fact does work. So I guess there's both a question and a caution there, in that you've got issues that are not surprising.
Right.
The way that you tackle them probably is multifaceted. That you do need to think about sensitivity analyses and trying different ways, and not be too, I guess, put out if things don't work quite the way you might want them to, because depression is a very different entity than schizophrenia.
Absolutely.
And I don't think it's really surprising. And acknowledging those weaknesses and saying, well, there isn't going to be anything that's going to magically solve the problems. But I like the fact that you're looking at different ways to even, how do we classify people, right? What are our labels? You're looking at different clinically relevant ways to do that, and you're really engaging with clinicians. So anyways, I'll stop.
Oh, no. It's a fantastic study in that we have so much clinical support in the work that we do. People like Glenda McQueen, who is from psychiatry, and psychiatrists from across Canada that are really sort of helping us understand what's important, not only in terms of building a successful model that has good accuracy, but something that's going to be meaningful for clinicians when we're all finished with it. So depression's a bit of a different beast, and it'll be interesting to sort of see how this all pans out for sure. So thank you.
Thank you very much for your talk. It's very interesting.
Thanks.
I'm not familiar with machine learning, computer science, but it's very interesting. I do catch up some things. And, about that graph on the people features, and then do the machine learning to get some labels. Oh no, then the very beginning.
Okay.
And labels, and use the model again to predict, to shorten the time from diagnose. Just the purpose of this one. I think it's quite interesting, but I have one question about the sample size, the number of participants used to training the model.
Right.
Is there any standard rule or general rule about the sample size? How many number of participants is required to training the model to make it performed well, to generalize, to represent the general population?
That's actually a really interesting question, and I think when I had arrived at the U of A, starting sort of my journey into machine learning, that was the first question I asked, and it was I still am seeking an answer necessarily on what the number is that we need. it's really hard to say. It sort of depends on a number of different things. So some of the things that we try to stick to, I use something like logistic regression as the model that I was using here. And as the complexity of your model increases, if you want to start using things like deep neural networks, you really need bigger sample sizes. So a lot of the times we're sort of stuck with these, not stuck with, they're very powerful, but more simple linear models because they're more appropriate, I think, for working with smaller sample sizes. The sample size is also sort of dependent on the number of features that you plan on putting in. So you really, as you increase the number of features that you work with, you really need to have a much larger sample size to be able to handle that. I think, yeah, it's a bit tricky. There isn't sort of a necessarily number you need. We did sort of have a conversation in one of my classes, and the question was, is there ever too much data? Would you ever like turn down data for your models? And I think the answer is no. More data for this is almost always better, and I think even now we have a relatively large sample to be working with, nearly 300 participants, and we would always love more. It quickly becomes smaller and smaller the more things you try to do, so yeah. But I think we're starting to get to the point with a few hundred participants where we can be a bit more confident in the modeling that we're doing.
Okay, yeah, thank you very much. I do have another question. It's quite, just, I'm not sure the when you recruit a participant for the machine learning, for example, if the other patient are from Calgary, then you build the machine learning. Can you apply the model to other city? Or you build a machine learning model based on Canadian population, then can you apply the model to other country? Just a very curious question. Thank you.
So no matter what, I guess if your underlying patient population changes, so I think this is a little bit of an issue, like if you built a model only looking at women, and then you tried to use it in a bunch of men, it probably wouldn't necessarily work that well. So as soon as your sort of underlying population changes that you built the model based off of, it probably won't work as well. But when it comes to things like batch effects, like if we're using data from a single scanner that we collected, and then we hope to say, okay, built this model based off data collected at this one scanner, I'm gonna go use that model somewhere else, collecting data from a different scanner, it probably won't work. There's too much noise and variance that's introduced from these different models, and that's really sort of the issue of batch effects. If we build these models at one site, it probably won't work if we go to another site. So how are we dealing with this, or how can we pull the data from all these different sites into sort of the same space so we can have models that, you know, we train it and build it here, but we can deploy it somewhere else. Otherwise, we're going to end up in a situation where every hospital, for every scanner that they have, has to train their own model, right? So that's one of the really big issues, is how do we build really robust, generalizable models that we could deploy to many different places.
I had one question. For the schizophrenia study, initially, what were you using as your gold standard? Coded data or chart review data for like charts from a clinic to make sure that you had true cases?
Oh, yes. So for the schizophrenia study, all those individuals were collected from a hospital in India as part of NIMHANS. So they are all psychiatrists. All the data that we use generally, a lot of the data we use is actually collected from sort of structured studies, as opposed to sort of mining data from things like electronic health records or other sources like that. So we do have probably as gold standard as it gets as far as diagnosis in psychiatry. How reliable, there's another question that comes out of that, is how reliable are the diagnoses from one doctor to another? And that's a whole other issue. But yeah, these are all individuals that have been diagnosed by psychiatrists in a hospital, and oftentimes by more than one psychiatrist. So we feel as confident as we can in these the labels we're working with.
Anyone else? Thank you so much, Jackie. Excellent. I just want to say a few quick words about the Center for Health Informatics, and then some thank yous. But just to remind you that we are a new center on the 5th floor of the TRW building. Come by and visit. You'll have to knock, but we'll let you in and show you around. So led by Dr. Huda Kwan and Tyler Williamson and myself, as well as an advisory committee from across a bunch of institutes here, to guide the research that's done. The purpose is to pull together people to collaborate, to work on precision health problems, and to bring them forward through collaborations, to advance training, like we've heard about today, around data science. And this is one event of many to come. We will have a speaker series. We will have joint lunchbox talks with OIPH. And we're seeing this new area as a virtual home where people can drop in, do work, stay for a while. Postdocs are coming, professors are visiting, and use the space. We are also going to be announcing a new high-performance computing cluster. Catalyst is being augmented through the clinical research unit to hold more data and compute faster with GPUs. We've instigated that, and we are also moving ahead with exciting forms of data access. Whoops, wrong way. Sorry. So the two forms of data that we have now piped directly into the center are Alberta Health Services, and as of today we have 4 methodologists directly employed by Alberta Health Services to access data directly, and we have 2 SPOR data platform scientists, Bing Li, Jason Zhang, who are employed there to help us get data out faster for our research. We have 2 more being hired, so for a total of 8. As well, Statistics Canada data is coming soon too. We've signed the contract with StatsCan to set up this satellite RDC for linked and numerous data sources. And that will be open sometime this spring with part-time availability initially, but it'll help Cumming School of Medicine researchers not have to go to main campus to access this type of data. And lastly, the whole point is that we are moving lots of raw forms of data through various technologies and techniques to become, make it more useful through visualization, through modeling techniques, to find ways of developing precision medicine platforms for making, helping physicians make better diagnostic decisions or treatments, and or modeling and predictions about people's health to help the public. So for more information, you can contact myself at my email address or Alyssa Lamb, who is working tirelessly to get our website up and to do all of those things that support the training and all of the activities that are going to take place in this new area. So Doreen Rabi has a few more words, and then I'll just close with a few more thank yous. Can you just grab this? Sure. Just turn it on.
Yeah, I think it's on there. Thank you. So thanks for hanging out until the very end. And I wanted to thank Kathy so much for bringing this amazing conference to the Cumming School of Medicine. I think you were just a wonderful ambassador for us, and you know, being someone who's longer in the tooth in terms of their career, I still got so much from this day, and I still value everything that was discussed on that panel. So no, thank you so much for bringing this opportunity to the Cumming School of Medicine. And so just to close, I just wanted to sort of reflect back on some of the things I said this morning. And it's interesting that in 2012, there was an article in the Harvard Business Review that said that the data scientist is the sexiest career of the 21st century. And while that was kind of a provocative word, I think what they're getting at is that it's certainly a highly desirable career, and it's a position in which if you have those skill sets, you're going to be very, very wanted in the professional community. And I think what we saw today through the breadth of projects that are being done, the incredible diversity in skills and methods that are being used, but also highlighting some of the common challenges that we have when we're dealing with big data sets, whether it be heterogeneity or validity of data definitions. I think there was lots of opportunity today to sort of, you know, identify with leaders in the field to sort of say, okay, some of their challenges, some of their problems resonate with me. And I think we had, you know, I'm leaving today with new collaborations and new work opportunities, and I'm hoping you are too. And in terms of the objective today, in terms of inspiring and educating women in data science, I think that it was a wonderful program, and certainly, hit the mark, if not greatly exceeded the mark on that one. And I'm very, very impressed that even though the numbers would suggest that we comprise 10 to 15% of the data science workforce, we're certainly punching well above our weight in terms of the contributions that we're making. And days like today, when you can, hear, amazing women speak, and be inspired by them, connect with them, and as they mentioned in the panel, have an opportunity to actually build relationships with these people. It's incredibly important, and I love that saying about, it's not a project that's going to bring you success, it's relationships. And I think that's, one particular strength that women bring to this field is that we are very, we're collaborative by nature. I think that we know that, that we succeed by elevating each other. So as much as some of you may have heard me speak before about sort of the gender gap and the barriers and the obstacles and the difficulty with our work culture, days like today really, really are heartwarming and inspiring to make us think that, we're better together, and the future is bright as long as we continue to really, really, really celebrate our strengths and really know our value. And when you're questioning your value, find someone who can help you rediscover what that is, because that's what's going to keep you in the game and help you succeed. So anyways, thank you so much again, Kathy. It was a really spectacular day. And thanks so much for coming. And for all of the men who might still be out there online, thank you so much again for supporting us and allying with us, and we appreciate your partnership.